Well, welcome everyone. We are so excited to have you with us today for the North Sound Oral Health Local Impact Network Fall Virtual Meeting and to have with us our guest Laura Brannon to speak on the state of oral health and related matters. And so we are going to get started here. I am Keiko McCracken, she, her pronouns. I am the innovation specialist here at North Sound. And again, we're just so happy to have you all with us today. We are going to ground ourselves first in our land acknowledgement with deep gratitude toward those who have been here since time immemorial. And so we begin by acknowledging with humility that the land where we are today is the territory of the people of the Salish Sea. Their presence is imbued in the waterways, shorelines, valleys, and mountains of the traditional homelands of the Coast Salish people since time immemorial. And with that, I want to start by just acknowledging some group agreements that we use here at North Sound to just help, create a positive container for our time together. That is to spread kindness, learn to disagree without breaking, allow for being uncomfortable as part of growth, be curious and ask questions, create opportunities for follow-up, share from our own experiences, use language that is respectful, accessible, and inclusive, and respect the privacy and confidentiality of what is shared. So again, thank you. Thank you all for joining us today. We're going to go over some brief tech tips for you all, and we have standing by Cassie, who is our tech person for today. If you have any issues at all, please reach out to her via chat at tech support in the chat function. But take a look right now at your Zoom control bar at the bottom of the screen to notice just a couple of options for you through this time. There is a Q&A function. If you have a question, be sure to make sure that we're aware of that using that function. You can raise hands to just let us know that you have a question and want to speak on something. There is an interpretation function that is available for you to click on that to listen to the section in, oh gosh, sorry. I'm so sorry. I just got a correction. We don't have a Spanish interpreter today. That was not requested by the attendees, so I apologize for that misinformation there. But again, if you have any issues at all, please reach out to Cassie using the chat and tagging her at tech support. So yeah, with that, I would love to introduce our speaker, Laura Brannon, who is the Senior Project Manager of the Dental Therapy Project of Community Catalyst. And we are just so excited to have her here with us today. Laura is, again, the Senior Project Manager for the Dental Therapy Project, which is a part of the Dental Access Project at Community Catalyst. And in this role, Laura oversees efforts to support the authorization and implementation of dental therapists across the country. Previously, Laura worked for the Pew Charitable Trust, supporting state-based campaigns to authorize dental therapists, and she also worked as a federal lobbyist for the American Society of Civil Engineers, covering transportation infrastructure policy. Laura received a bachelor's degree in political science from the University of Notre Dame, and please join me in welcoming Laura Brannon to our meeting today. Thank you so much, Laura.
Hi, thank you for that introduction. Sometimes people ask me how I wound up doing both infrastructure and oral health, and I said it's all about the bridges, guys. So that was a terrible joke. I'm assuming you're all groaning off camera, but I have thankfully distracted you while I try to share my screen. There we go. All right. So as Kiko kindly said, I do focus primarily on dental therapy and really sort of workforce topics broadly in my job. But I'm going to be talking a little more broadly today about oral health. and about oral health policy and specifically why that matters. Now, I also know that in the room today, we've got people with a lot of varying levels of experience on oral health. We have dental providers, we've got community health workers, there are advocates, there's people who have spent decades of their careers in oral health, and there are people who are aware this is an important thing, but they don't know much beyond that. We're going to have information kind of at a range of levels, hopefully offering some level setting for folks, but also offering some content even for experienced professionals, hopefully that will be new to them, really aiming to give people the information they need to be advocates and spokespeople for oral health equity in their communities. So to introduce Community Catalyst, we are a national nonprofit dedicated to building the power of people to create a health system rooted in race equity and health justice, and in a society where health is a right for all people. We do this by partnering with state-based, tribal, and regional organizations to try to advocate for policy change, as well as elevating things to the federal level and trying to affect policy change there. So we work on a wide range of issues, but I specifically am on our dental access project. Community Catalyst Dental Access Project is working to address inequitable access and other barriers to care. We have been doing this work for 14 years, although I have not been on the team the entire time. We've worked in over 40 states, and we have 5 staff. So we do work on a wide range of issues beyond just dental therapy. So I also want to say, please know that our team exists to provide technical assistance to advocates and policy folks working in the field. So please also feel free to reach out if you want to have a conversation about oral health afterwards, about dental therapy, or about any of the things we talk about today. We are always really excited to make new acquaintances. So just a question for the chat, if folks wouldn't mind putting it in, just to start our thinking a little bit. When you hear the words oral health, what comes to mind? And really just go for whatever like the first couple words that pop into your head are. So I am going to start by talking about the impact of poor oral health, and we're going to get into more the why that exists and what we could do about it later on. But I think it's important to ground us in first, but really the piece around why oral health matters. So I know this is a newsflash to a lot of people, but your mouth is actually part of your body. And the health of your mouth and of your teeth and your gums and everything really impacts the rest of your body. And it impacts it in a lot of different ways, and a lot of ways that I feel like science is really just starting to understand. So we've known for a long time that dental disease, untreated dental disease, impacts people's ability to eat, and that can lead to malnutrition. I can say I had a grandmother who by her 50s, I think, was completely edentulous. She had no teeth and she had no dentures for a very long time. So it definitely affects the nutrition she could get when she was not able to chew meat or fresh vegetables or things like that. And we know this is not a unique story. Oral health conditions are also related to things like diabetes, heart and lung disease, dementia, Alzheimer's. Untreated dental disease during pregnancy can impact preeclampsia, adverse birth outcomes. So, inflammation, infection, chronic inflammation and infection, particularly in the mouth, can have massive impacts on the health of one's entire body. And I think this is not something that is widely recognized outside the medical system. I know we have oral health providers on the call today. So in some ways, it's a little bit preaching to the choir, because I feel like oral health providers have known for the importance of oral health for a long time. The rest of the medical community, I think, has been a little further behind, but is getting there. And I think there are more understanding of the connections between oral health and overall physical health, which we are pleased to see. So, excuse me one second. So thinking about the stigma of bad teeth. So we talked about the physical impact, but I think the emotional and social impact is just as bad. And I really want to say I'm putting bad teeth in quotes here. But what we talk about are mostly non-aesthetically pleasing teeth. In a lot of ways, we have a dental system in the United States which is devoted to straight, white, attractive smiles. Like that's what a lot of dental advertising is about. It's about protect that smile, enhance that smile. You can get, veneers and cosmetic dentistry, a lot of ortho to make sure your teeth are perfectly straight, a lot of teeth whitening. Whereas there's less attention, I think, frequently paid to the serious oral health conditions that are impacting a lot of community members. And, I frequently say that bad teeth in America are the most visible class symbol in our society. And I think we all know there is a very heavy stigma on bad teeth. And this can have massive impacts on people's lives. It is strongly linked to depression, to low self-confidence. I think a lot of people have probably encountered someone who, when they talk or when they eat in public, frequently hold their hand in front of their mouth. And this is a really common story, particularly I hear when I go into communities with low access to care or talk to people who will work in those communities. People have a lot of shame about missing teeth. And also, quite frankly, in popular culture, we treat
Can I just
tooth.
chime in? Sorry, and it's really crazy because oh, sorry, wrong
No,
one.
please.
Sorry, I multitask with multiple meetings, so I'm trying to click on one meeting and not the other. So my apologies.
No worries. So also in popular culture, missing, unaligned, unattractive teeth are used as a shorthand for being uncultured, of low intelligence. Literally, as we have a lovely picture here, they sell what they're calling Billy Bob teeth in costume stores at Halloween. And I think, like, how many other medical conditions do we think it's appropriate to sell Halloween costumes of? That is both like how stigmatized poor oral health is, that we just really think that it's an acceptable thing to joke about, and to stigmatize people who have that. Also, when we particularly consider all of the systemic reasons that people have that, when we look at poverty, inequity, structural racism, it is, I would say, really a system of people, frequently a society that has sort of given people poor oral health and bad teeth and then mocked them for it. So also, as we've talked about this, there's massive stigma against sort of bad teeth, and that this has a massive impact on people's economic well-being, on their ability to get jobs, and on how much money they will earn over their lifetime. We know just untreated dental disease causes a lot of missed days of school and work. If you have ever had a toothache, you know it is incredibly painful. It is hard to eat, it is hard to sleep, it is hard to concentrate. So it's going to be hard for people to go about their daily life when they have that happening to them. And, I've never had a toothache for more than a couple of days. I have met people who have had toothaches for months and years. If you think about the cumulative impact on someone's physical health, on their mental health, and on the rest of their life from chronic untreated pain like that. And as we said, there's been a lot of studies that actually show this empirically, that people with missing front teeth, are less likely to get jobs. They are likely to earn less money over the course of their lifetimes. And because of, the way structures intersect, we also know this is more pronounced for women. There is a stronger appearance bias on women, and therefore women in particular who are missing teeth will make less money over their lifetime. And I think this is also something a lot of us have heard stories about if we work with community members. I had somebody tell me once that they'd gotten a job, which they were really excited about, but in the office they were working in, they said, "Oh, but we can't put you in a customer-facing role. We'll have to put you like in the warehouse. If you get your teeth fixed, then you could be up front. But right now you don't look good enough to be up front." Of course, the position they wanted to send her into was more physically demanding and made less money, because she was not considered like an appropriate representation of their business if she had a missing front tooth. So I think a lot of people may have encountered the book Teeth by Mary Otto. Highly recommend if you haven't. But there's a quote from it I particularly like, which is, "The teeth are made of stern stuff. They can withstand floods, fires, and even centuries in the grave. But the teeth are no match for the slow motion catastrophe that is a life of poverty." So, as we've talked about, of course, none of these things happen in a vacuum. The people who are most impacted by these challenges are not a randomly selected group of people in our society due to our history of racism in this country, due to structural barriers. Um, they are strongly correlated with both race and income, and race and income obviously are interconnected in this way. So we know that communities of color are far more likely to be missing work and school due to oral health problems. They are less likely to be receiving regular access to care. They are more likely to have high levels of dental disease, and all of this then is correlated with being with having lower incomes. So, this is really, we talk about the cycle. Frequently, I was talking with a community member last week, and she was talking about how, I think in her words, poverty gives you bad teeth and then it keeps you poor, which I was like, yeah, that's the tagline right there. Like, that is it in a nutshell. So one extra little thing that I think is a good illustration of some of our problems and the symptoms they create is veneer text, which I'm not sure if anyone has learned about this yet. If you haven't, it's probably a sign you don't spend too much time on social media, so you should probably be proud of that. But the topic of veneer text sort of blew up on TikTok and Instagram earlier this year. And if you've never heard of a veneer tech, they are basically someone who is not an oral health professional. They have taken an unaccredited weekend course, usually, in applying veneers, like no prep veneers. And then they usually open up like a little studio using equipment that they buy online, frequently on Temu. And these training courses are promoted to people, usually who are low income people of color, both as like a job opportunity, saying like, oh, you've heard of being a lash tech, you've heard of being a nail tech, you could be a veneer tech. And to the target population who they want to pay to get these veneers, realizing that frequently we're looking at a community which has less access to care, has higher rates of dental disease, because those cross-cutting interplays of structural racism and income in our society. And then we have tremendous pressure, both social pressure and economic pressure, to have an attractive smile. So this really creates an environment in which these sort of unsafe, predatory industries can flourish. They've also not been, like dental boards in a number of states have actually been quite slow to respond to this, because they've said, well, they're not dental providers, and we only regulate dental providers, which has been concerning if these are folks out there supposed to be protecting public health. So this is something that I think is really kind of a symptom of our existing, the failures of our existing oral healthcare system. Also, if you know anyone who's thinking about going to a veneer tech, please tell them no, it's a very bad idea. So another impact is, of course, debt. Dental debt is one of the leading drivers of medical debt in the United States. About half of cases of people with medical debt say that dental debt is part of that debt. We also know that people who have dental debt, about 60% of them have dental coverage. This is not a case where it's, oh, well, if everyone just had dental insurance, then no one would be in debt. No, that's very much not the case. Like medical debt and dental debt are extremely common in our society. 41% of adults in the United States have either medical or dental debt. And there's a new kind of debt that's also been growing really quickly, which some folks may have encountered, which is called care credit. This is mostly offered by sort of like Wall Street backed companies. There's been rapid growth in this. A lot of them have been investing in this. And then they go to dental offices. They also sometimes will go to veterinary offices and other medical offices, but dental offices have been their primary growth opportunity. And say like, hey, your patients frequently have difficulty affording dental care. And that's true. I think a lot of dental offices say, yeah, that is definitely the case. They said, well, you could partner with us and offer a care credit, which sounds really wonderful. It's usually something like a 12-month interest-free loan. And it sounds almost like a public health sort of program. And people are like, oh yeah, care credit. That sounds caring. That sounds like something that could really help me. I'm in a spot. I need, I need a filling. I need a bridge. I need a root canal. But the problem is, these things really function a lot like payday loans. So if you know anything about payday loans, this is a situation in which basically people usually in desperate situations get somewhat tricked into taking out debt that they don't understand the full implications of. Usually a care credit can come with hidden fees. It's considered a deferred interest loan, which means if you pay every dollar back, usually within 12 months, you have no interest. But if you are one day late on any of those payments, all of a sudden there's a giant bunch of interest that you now owe. So there's a lot of fees associated with that as well. And so frequently that is not well disclosed to patients also when they are, frequently in kind of a desperate situation, thinking like, okay, this could be my way out. And this can really trap them in the cycle of debt. And frequently people with that medical debt end up going and getting into more debt, looking at things like credit cards and those payday loans to try to then pay back the other debt. And it really, the cycle just gets worse and worse. So talking about this medical financing, so the medical financing industry, as I mentioned, has been growing really rapidly. There was a big report that came out about this recently. It discusses the fact that rising national healthcare expenses and declining private insurance coverage are driving consumers to seek medical financing. And the dental industry is a prime target because there is a high cost for these procedures that insurance doesn't cover, and that of this new rapidly growing medical financing industry, dental financing consists of 59% of the industry. So this is something that Wall Street is really going after, realizing that there is a lot of money to be made basically off of poor folks who can't afford their dental care. And we know that poor and near poor households earning below or slightly over the federal poverty level are contributing considerably to the industry's revenue. Just another quote that I really relate to is there's an excellent I think it's an essay by an author called Sarah Smarsh called Poor Teeth, which I highly recommend looking up as discussing her sort of experience of having grown up in poverty. And she mentions, poor teeth, I knew, beget not just shame, but more poorness. People with bad teeth have a harder time getting jobs and other opportunities. People without jobs are poor. Poor people can't access dentistry, and so goes the cycle. So I think all of this is, really reinforcing this idea that all of these things are interlinked. And so when we're looking at solutions, we need to look at solutions that can help break this vicious cycle. So now we have a discussion question, and I think that you guys are going to go into some little groups to talk about it. And we're going to have a couple more discussion questions because I really want to make sure that this is not just me talking to all of you, but you having a chance to reflect. So out of all the topics you've seen discussed so far, discussing the physical, mental, and social costs of poor oral health and inadequate access to dental care, how do you see this play out, like whether in real life, whether in popular culture, whether in your own experience, or just seeing it through your work? So that is the discussion question, and I'll hand it over to whoever is doing breakouts. All right. I hope everyone had a good conversation in their breakout rooms. And we are going to have, I think, another two later on, just to also give folks a chance to reflect, and then, just a broad discussion at the end. So want to make sure that, as I said, this is not just me talking at y'all, but that all of you are sharing your thoughts and opinions and reactions and your knowledge and expertise as well. So we are going to keep going. And talk next a little bit about coverage. So looking at, what is causing all of this that we've talked about, the fact that we have massive oral health inequities in our society, that while oral health is incredibly important to someone's physical, emotional, and economic future, that we have a lot of untreated dental disease, a lot of poor access to care, So what is really driving these things? Well, a lot of it, I would say, begins with coverage. So dental coverage is one of the major factors that affects whether or not a person gets dental care. We know that people without dental coverage have far greater financial barriers to getting dental care, and that they're much less likely to receive oral health care in a given year. And we also know that people with private coverage are more likely to be getting care as well. We'll talk a little bit more about why that is in a minute. So who has dental benefits in the United States? Well, first we need to go over the fact that dental coverage is optional in a way in the United States, that it's not for medical coverage. I think, everyone knows post the Affordable Care Act, the number of people in the US who don't have any health benefits is a lot lower than it used to be. However, we still have 27% of Americans who lack dental coverage, which is 3 times the number of people who lack health insurance. Now, some of that is because people are not able to get those benefits, although I also know some people feel like it's not actually a worthwhile product for them, and that they're better just paying out of pocket because of some of the limitations on dental benefits that we'll talk about in a minute. Medicare does not include dental benefits, at least traditional Medicare doesn't. Some Medicare Advantage plans, which are those sort of private plans, do, but traditional Medicare, which is what most people are on, does not include any dental benefits. Medicaid for adults is not required to cover routine dental care for adults. And the coverage really varies by state. So we have some states that have pretty comprehensive benefits. And some states that really only cover like emergency situations, like you have an abscess and need a tooth pulled. And even though I would say in states technically with good coverage, there's a lot of limits on what they will cover. I've heard from a lot of community members who, when they have a situation where they might need a root canal, frequently Medicaid will only pay for an extraction. Or if they do get an extraction, Medicaid won't pay for a bridge to cover it. They say you have to have 2 or 3 teeth in a row missing for it to be bad enough that we think that this is affecting like your ability to chew for us to cover it. So, the coverage really varies by state, and it is it can still leave a lot of costs for folks if they want to be able to say keep their tooth and get that root canal, or actually get that tooth replaced and get a bridge. Also, as folks may know, we went through something called Medicaid redetermination this year, which is basically during the pandemic, there was a public health emergency, which suspended checking people's eligibility. So if they had joined Medicaid during the pandemic, that they got to keep their coverage. So this year there was an end of the public health emergency, which meant that states could require everyone to re-verify, which sounds like, okay, well, maybe some people who shouldn't be on Medicaid might be removed. But the problem was, we know most people who were getting removed from Medicaid were not getting removed from Medicaid because they were no longer eligible. They were getting removed for paperwork reasons. They were getting removed because they never got the forms that they needed to submit, or that their state, had an old address for them. This is basically a massive problem across a lot of states. Some states, I think, did much better than others, but some states basically kicked off a really large number of people who should have been eligible due to basically paperwork errors. And we know that in 2024, about 14 million people nationally lost Medicaid coverage, some because their incomes were actually too high. But again, a lot of them had incomes that should have made them eligible, but lost it for other reasons. So if we look at a graph that talks about where people are getting their dental coverage, we see the largest source is private insurance through their employer or their union. That's about almost 60%. After that, we have about 12.2% who are receiving that coverage through Medicaid, about 11.3% over there on Medicare Advantage. We've got maybe about 7.6%, almost 8% there of people who are buying their own plans on the marketplace. And then we've got like a few other things like state-sponsored health plans, the military, the Children's Health Insurance Program, and the Indian Health Service. And when we look at why people are losing coverage, you know, a lot of that was, again, that 9.8% over there was due to changes in benefits due to COVID-19, that Medicaid redetermination. A lot of people lost their Medicaid dental benefits. So an important thing to remember is that while coverage is important, coverage frequently sort of has to be the first step. Coverage does not necessarily equal care. Care is often inaccessible for people even with dental benefits. Most private plans have a maximum cost that they will pay per year of about $1,000 to $2,000, and they have high cost sharing for advanced care. So if anyone has ever had to get a root canal or a crown or a bridge or, God forbid, an implant, they know that the vast majority of that cost is coming out of their own pocket, not out of the dental plan. And there's a reason that dental benefits are, I do sometimes use the words dental insurance and dental benefits interchangeably, but they're not technically insurance. Dental benefits are not insurance. Insurance, like health insurance, generally, the more risk there is, the more they cover. But dental benefits, with the way they have a maximum and everything, they are not technically insurance, and they're not held to the same standards that insurance is generally held to. We also know that 2/3 of dentists don't accept Medicaid. So particularly when we look at why are people with benefits through Medicaid so much less likely to be getting dental care than people who have private insurance, the answer is because so many clinics don't accept Medicaid. And places that do, like community health centers, often have really, really long wait lists. I do work all across the country, and I was talking to the CEO of an FQHC in the Finger Lakes region, which is in Western New York, if you know it. And she told me that they recently closed their waiting list for dental care because it was 15,000 people long. And at that point, there was just really no point in trying to add anyone else to that list until they could get through it. So I think most clinics are probably not in quite as bad a shape as them, but we know that for folks on Medicaid, it can be really difficult to get care. It can mean long wait times or long travel times to try to get to a clinic. We also know that about 1/4 of US adults have had to put off dental care due to cost, which is frequently really gambling with people's health, knowing that when oral health problems are not treated early, they're likely to get bigger. Also, if you look at the little graphic, you will see the percentage of people reporting cost barriers to dental care. Unsurprisingly, the lower income you have, the more barriers you have. So that's pretty much what we would expect. The Fed does a study pretty routinely, I guess every year, where they look at how many Americans are skipping medical care due to cost. This is something that they have surveyed people on for at least a decade. And if you look at the graph down here in the bottom, you notice that there has been an increase in recent years. And also, of the different kinds of medical care that people are skipping due to cost, dental care is the most prominent. Dental care is coming in at the top, with 21% of people, adults, I should specifically say, 21% of adults in the United States in the most recent year, which they have data from, which was 2022, said that they had to put off dental care due to cost. So that's about 1 in 5 adults are putting off dental care due to cost. As probably would not surprise you based on any of what we've talked about, is your chances of having a dental visit is extremely correlated to income. That is a pretty straight line right there when we look at that graph. People in poverty are much, much less likely to receive dental care in any given year, while people with higher incomes are much more likely. I had a public health expert once described it to me as the people who need the most care get it the least in America, which feels pretty accurate. So there's a lot of cost of what I would consider the status quo. There's a lot of cost to human beings, but there's also cost to the system, particularly when we look at ER usage. It's really difficult sometimes to capture what is the cost of all of this oral health disease in America. That can be a really hard thing for I guess, a scientist to capture when we look at what is all of the cost of dental disease. But one of the easier ways to capture it is looking at the cost of dental visits to the ER. We know the vast majority of people who go to emergency rooms for oral health conditions are not going due to like getting hit in the mouth with a baseball or something. They're going due to dental disease. They're mostly going due to pain and infection from, something that began as a cavity and frequently has turned into something like an abscess. They're going because they're in really intense pain. The problem is the vast majority of emergency rooms in the US are not equipped to treat dental problems. Doctors do not get a lot of instruction in oral health in medical school, and they don't have a lot they can do except sometimes give a patients some antibiotics. At one point, they were frequently prescribing opioid painkillers, although that I think has been greatly decreased in recent years. And then they tell them you should really find a dentist. Problem is most people are winding up in the ER in this situation because they haven't been able to find a dentist. We know that it's approximately $2 billion every year in the United States that is spent on dental visits to emergency rooms, and most of that is being covered by either Medicaid or by other public programs. So, it is really sort of wasteful spending when we look at if we had been spending those $2 billion on getting people the care that they needed when they needed it in much cheaper settings, treating those oral health problems when they were, preventing them or treating them when they were small cavities as opposed to enormous abscesses. We could be getting a lot better health for the amount of money we're spending on healthcare in this country. So one new sort of bit, I feel like I've been a tiny bit of a Debbie Downer, but sometimes there are new opportunities. So one exciting new opportunity that has emerged this year has been around the essential health benefits. So you may have heard of the essential health benefits, but basically when the Affordable Care Act was passed back in 2010, the Affordable Care Act being what we commonly refer to as Obamacare, it created a list of essential health benefits. And these are categories of services that most health plans have to cover. So you may be familiar with it, particularly around things like preventive care, vaccines, and birth control were some of the things that were on that list, and greatly increased the number of people who were able to access those things because this sort of new list said that health insurers had to cover those things. So the feds have their own list of essential health benefits, and then states can have a list as well. The federal list is the floor, and states can raise the floor by creating their own list if they wish. But the federal list of essential health benefits that was passed as part of the ACA created pediatric dental benefits, but didn't include routine coverage for adults. And actually, the ACA prohibited states from adding adult dental to their own lists of EHBs, which a lot of advocates really fought against. But now, 14 years later, the feds have finally listened to a lot of oral health advocates who've been advocating for a really long time on this, and they have lifted that prohibition. So what does that mean? What this means is that states are now free to add routine adult dental benefits to their own list of essential health benefits, which would mean that all health plans sold on the marketplace in their states would have to include coverage for dental care. What does that actually do? Well, if you think about the fact that if you are someone who is lower income right now, if you make too much money to be covered by Medicaid, but you are sort of in that middle spot where you would get subsidies if you bought a plan through the marketplace, those subsidies don't apply to dental plans currently. So you could get a health plan with subsidies applying for it to make that more affordable to you. But you can't get a dental plan. You'd have to pay full price for a dental plan. But if the health plans had to include dental benefits, either by the health plan actually just creating like their own dental benefit, or if they partnered with a company that sold dental benefits, then those subsidies would apply. So that would mean that when someone bought their health insurance, it would include dental benefits, the subsidies would apply, so the dental benefits would be a lot more affordable, and ultimately this could result in more people having dental coverage and hopefully able to get more care. So this is an opportunity So the CMS lifted the restriction earlier this year. States have until I believe next May to notify the federal government if they intend to add dental to their list of EHBs. And so unfortunately, everything at the federal level takes a while. So the earliest this would actually take effect for consumers would be plan year 2027. So if states notify the feds by basically mid-year next year, plans sold in that state starting in 2027 would cover it. So I know this is something that folks in Washington have been interested in. Really encourage everyone to talk more about this and to make sure that you're talking to the folks at the state, because there is, kind of about a 9-month window for the state to take action on this, which could increase the availability of more affordable dental benefits in the state. So we are going to go to another breakout now. So we've talked a lot about who has dental benefits, where do people get them, where are people not getting them, and the fact that having dental benefits doesn't necessarily mean you're actually getting care, whether because there's a financial limitation on what they'll cover, or because if you're on something like Medicaid, it can often be just impossible to find someone who will even accept your insurance. So we're going to do a breakout now talking about how have you seen the way our dental benefits work in this country impact people's lives. All right, welcome back, everyone. I hope you had a good conversation with your breakout group. Would anyone like to share something from their breakout room before we keep going? And just feel free to raise your hand, or I think you can just take yourself off mute and speak up.
I briefly brought up the issue with children with special needs and how their coverage, oftentimes they don't get that through Medicaid, they don't get that special coding to get a specific provider or type of coverage. And so those children always, we found in Whatcom County, oftentimes face a really big barrier to getting seen at period by dental providers and having to refer them further out. And so that really impacts their oral health, because we've found that many families will just essentially get frustrated and just kind of lose hope, until we find them someone and get them maybe a gas voucher to get to those providers. So I think it really does impact their lives. I had a mom that I was working with who was literally in tears because she was trying for so long to get her son in with a provider. So yeah, children with special needs encounter a whole other set of barriers, I think.
That is absolutely true. I've heard from folks a lot about that. And even just hearing how many dental offices will just say no, because dental providers feel like they don't know how to work on somebody with a disability. How many dental offices are just not physically accessible for a lot of people if you're in a wheelchair? And yeah, that is a really acute crisis. But yeah, I think if you look at the rates of who's not getting dental care, people with disabilities have some of the lowest access rates. So that is a very, very good point. Yes, kids and adults, I should say adults as well, definitely not just a pediatric issue. Anyone else want to share?
In our group, Allie said something, I think pretty impactful. You can always tell the people with Medicaid because they just get their teeth pulled.
That's absolutely true. I've had because I've been lucky enough to work across the country on this issue. And I had once in the course of a couple of months, 2 different community members on opposite sides of the country say almost the same thing to me, which was they're both older women had been on Medicaid for a long time. And they said, I feel people say that we don't care about our teeth, that like our communities don't understand. Just like, why is it every time? They both said, why is it every time I go to the dentist, I feel like they're just trying to snatch my teeth out of my mouth. Like I'm here trying to hold on to my teeth. And I feel like it's a system that's just trying to take them from me. All right. Oh, go
I
ahead.
put this in the chat before we switched into the small groups, but I feel this information you shared about the CMS lift on the prohibition for states to add adult dental as an essential health benefit, that feels really big and like a potentially a huge opportunity. And I'd be curious to hear if you know of other states that are, advocating strongly for this, if you know about, or if anybody on the call knows what's already happening in Washington to advocate for this, or what the possible strategies might be.
Yeah, so I can say I know that a number of other states are exploring this, and I know there are some folks in Washington as well. I got to come out to Seattle 2 weeks ago to meet with a smaller group of folks, more specifically to talk about dental therapy. But I know there were conversations as well about that. But I don't know. Does somebody else have a better answer about? I'm sure someone is leading an effort in Washington on this, but I'm not sure who specifically to direct folks to.
I see Glenn is on the call. I don't know if he might know something or if there's anybody from our Cora that might know something.
About the adding the dental benefit to the HBs.
Mhm.
Yeah, it's funny that you ask, because I was just now emailing our advocacy people to see if they know anything about it, because I don't. But if I get an answer before the end of the webinar, I'll let you know.
And Glenn, if you do, even after, I'd love to connect, and maybe there's a group, from the LIN that would want to do some advocacy work around that.
Sure. Yeah, I'll let you know if I find out.
I can tell you, it varies state by state who is the decider. In some states, it's something that can be done administratively, and in other states, it does require legislation. One of my colleagues put together a good list, sort of state by state, of who the decision makers were. So I can also share after this meeting what we specifically know about who gets to decide it. Parrish, who works with me, just shared in the chat that according to some of our research, the Office of the Insurance Commissioner, in collaboration with the Healthcare Authority, are the folks who decide for Washington. So I would say it sounds like the Office of the Insurance Commissioner and the Healthcare Authority are the folks you want to be targeting to make some noise too. But all right, so we're going to keep going and talk a little bit more about the oral healthcare system, and specifically about workforce. So some of this, again, maybe things that you already know, but there are a lot of communities in the United States that don't have enough dentists. Particularly 57 million people in the US live in areas without enough dentists. And this is not just a shortage of dentists. There are widespread shortages of hygienists and dental assistants in the United States as well. I think some of the data I've seen says that the current shortage of hygienists and assistants is actually more acute than the shortage of dentists. So right now, in general, we don't have nearly enough dental providers. The pandemic really exacerbated, in particular, the shortage of hygienists and dental assistants. Also, our dental workforce does not look necessarily like the patient it serves. We don't have great data for all of the professions, so this is only looking at dentists. But if we look at sort of the distribution of the US population compared to the distribution of dentists by race, we see that a number of communities are underrepresented, particularly Black communities, Hispanic communities, and particularly American Indian and Alaska Native communities are very much underrepresented within the dental workforce. And we also know that people can have more positive experiences if they feel like they have a dental provider who they feel safe with. And sometimes that does mean sharing some sort of cultural background, or even someone who just speaks their language or is a member of their community. Patients are better able to build trust if they feel like they are in a safe place where they are not being judged and that they're being understood. Also, I would say the dental team is changing. So if you think about what maybe a dental clinic was like when you were a kid going, you might have seen a dentist, there was maybe a dental hygienist, and probably a dental assistant. Now, who's all on that dental team has really changed these days. Some clinics are still going to really look like that traditional mold, but there's a lot of other folks involved. And I would say this is a lot like medicine. You know, the folks that are involved in the medical team have really evolved and changed over the years, and we are seeing that in dentistry. I'd say dentistry is kind of a few decades behind, but we are seeing much more a shift towards team-based care. We have more dentists pursuing specialties, and we have new specialties of dentists. I learned recently orofacial pain, dentists who are specialists in conditions like TMJ. You know, so there's more and more different kinds of specialist dentists. You know, we continue to have dental hygienists, but we are letting dental hygienists do more, which is wonderful. We have our dental assistants, and we have expanded function dental assistants in a lot of states as well, folks who with more training can do more. We have dental therapists, who I know you have now authorized in Washington, and we'll have a few slides specifically about those in a minute. But community health workers are also a really important part of the dental team in a number of places. Not all clinics, I would say probably most clinics are not using them yet, but ones that are finding them a really great addition to the team. I also have folks like care coordinators. Sometimes they follow the community dental health coordinator model. Sometimes it's not that specific, but individuals who can also, like a community health worker, sort of be an interchange or play the role of being the connection between the community and the dental office. And we also see medical providers. More medical providers are sort of playing a role in oral health as well. So, you know, I did get asked to talk a little bit about dental therapy. As you guys in Washington, this is a pretty relevant topic for all of you. So in case you don't know about what a dental therapist is, I'm just going to do a quick little recap. So dental therapists are licensed oral health professionals, and they work under the supervision of a dentist. That can be a direct supervision, so the dentist is right there next to them, or it can mean general supervision. So the dentist might be in a different facility and collaborating with that dental therapist via telehealth, and the dental therapist working under sort of standing orders, the way like a nurse practitioner might. Dental therapists can do both preventive and routine restorative care. By routine restorative, what we usually mean are things like fillings and basic extractions. You know, across the United States, they work in a variety of settings, sometimes in dental clinics and sometimes in community settings. In Washington, the law allows dental therapists to work in tribal clinics, in federally qualified health centers, and in FQHC lookalikes, which are sort of similar safety net clinics. So what can a dental therapist do? So they are going to do a lot of kind of exams. So they can do an x-ray, they can do an exam, they can do treatment planning within their scope of practice. So that means that if they're working in a setting where they don't have the dentist on site, they can still do that exam, create a treatment plan, and go ahead and start to treat that patient. There doesn't have to be you need to come back sort of steps. So that can really help patients actually get their treatment plans completed. They can do prevention as well. They'll do oral health instructions. They do cleanings and sealants and fluoride varnish. It is important to note that dental therapists are not the same thing as dental hygienists, and I do get asked this a lot. Dental therapists are going to focus much more on that routine restorative care. In most states, dental therapists are not allowed to do some periodontal procedures. I think in Washington, they might be. But generally, dental therapists are going to spend most of their time in both education and in practice on doing more of those routine restorative things, while hygienists are going to continue to be the experts on things more like prevention and gum health. So sort of the bulk of what a dental therapist is going to do are these treatments: fillings, placing temporary crowns, extracting baby teeth. They can do limited extractions of adult teeth, basically non-surgical ones, which means that they can't cut or section. They can dispense medications like antibiotics, and they can do local anesthesia. In some states, they can also do nitrous. I don't remember off the top of my head if they can do nitrous in Washington or not. So what education do dental therapists get? So the Commission on Dental Accreditation, which we call CODA, sets education standards for dental therapy as it does for all dental education in the US. So if you look at a dental school, if you look at a dental hygiene school in the US, they are all accredited by CODA, and CODA sets accreditation standards for dental therapy as well. By the standards, dental therapy education must be at least 3 academic years. Some states have added extra requirements saying it has to have a specific degree, like a bachelor's or a master's, or saying that dental therapists have to be hygienists first. But there's been kind of a pushback to that because adding extra education requirements can increase the time and cost it takes to become a dental therapist. Washington does not have those extra requirements. I should say that some other states have also created advanced standing programs for dental hygienists who wish to pursue dental therapy as well. I know there is a college in Washington, Eastern Washington University, which is looking at doing something similar. So for our hygienists who want to learn to do some more things, that could be an opportunity. And there is also a CODA accredited dental therapy program already in Washington State at Skagit Valley College. So you might say, where did all of this come from? And I should say, I did not set out to work on oral health scope of practice. I have now spent 9 years of my life doing dental therapy. And most of the folks I know who also work on this issue did not come from an oral health background, but came to this because they saw this as a community-led solution, as a solution that didn't come from a think tank or from the federal government, but from the communities with the least access to care saying, actually, this is what we think would help us. Specifically, dental therapy came out of Alaska tribal communities who had grown tired of a constant shortage of providers, having to have their community members travel a long distance to get dental care. And they said, what if we tried to find a way to make it an accessible education pathway for sort of routine dental care that community members could get this education, that it would be cheaper and faster than dental school, therefore more accessible for folks, something that we could do at something like a community college or a tribal college. And that could really help sort of extend the reach of dentists, absolutely still having dentists involved, dentists being the head of the dental team, supervising dental therapists, but realizing that this could be a care extender. And it turned out it really worked. Dental therapists have been in Alaska for 20 years now. And this was not just an Alaska problem. Communities across the country want better access to care, and they also want better care. And I get asked this question a lot sometimes when people are like, well, that sounds interesting for Alaska, but Alaska's pretty unique. It's really rural up there, which is technically true. But it doesn't matter if you're 500 miles or 500 yards from a dental office if you're not able to get care in that, whether it's because you have a disability that prevents you from being able to get there, or because they don't want to treat you, because they won't accept your insurance, or because you're a working person who works 9 to 5, and that's the dental office is only open 9 to 4 and you can't get the time off. Or frequently what it is also because you can't afford the care that they're offering. So dental therapy can really make sense across the country. And communities in particular, low income and communities of color really wanted providers who were a part of their community and who would be there in the long run. We do have a lot of programs in this country to help incentivize medical and dental providers to move to high need areas, which are great programs like the National Health Service Corps. Like, these are definitely important, but this can also create a revolving door of providers for a lot of these communities, and patients feeling like they never get a chance to build a long-term relationship with their provider. Their provider never really knows them or knows their community. There's really not a lot of cultural competency, and patients saying, I would like to actually build a relationship, and I would like maybe the provider to speak my language, to actually be here, a member of my community, to be someone I run into in the grocery store, as opposed to just feeling like people just cycle through before they get their sort of loan reimbursement and move back to somewhere else. And also that wanting that accessible education pathway is really important. Wanting to figure out how can we be rethinking education a little bit to think about accessibility and affordability, and thinking about how are we making it so that the people from the communities with the least access to care have an opportunity to become providers, which not only creates better access to care, but also creates good paying jobs in those communities as well. So dental therapy in Washington began, the first dental therapist began in 2016. In 2016, the Swinomish Indian tribal community authorized dental therapy as a sovereign government is able to do that. And they hired, Daniel Kennedy, who's pictured there, as the state's first dental therapist at their clinic. In 2017, the state legislature passed a law officially authorizing dental therapists in tribal communities in Washington. While, as I said, tribal communities as sovereign governments have the right to hire dental therapists without state authority due to a number of complicated federal reasons. If they do that, they are not currently able to use Medicaid dollars or IHS dollars for their dental therapist services. So having them authorized by the state did open up some more funding streams for them. In 2022, Skagit Valley College opened up an accredited dental therapy program, and they did that actually in partnership with the Swinomish tribe. The first year of training, I think, is on Skagit Valley College's regular campus, and then they actually use the Swinomish dental clinic for their second year of actual clinical training. So it's a really cool model of how like how a tribe or even like a community health center could partner with a college to help make that training more accessible, because it really reduces the need for something like a community college to build a new dental clinic. So that was a really cool model. And then last year, legislation passed the Washington legislature to expand the authorization of dental therapists from just tribal communities to also include FQHCs and lookalikes. And I should say right now, the dental board, DQAC, is working on the rules for dental therapy. So that is still ongoing. So I just want to take a step back and talk a little bit about some of sort of the changing forces in dentistry to just provide a little more context. So there's a lot of change in how care is being delivered broadly in dentistry. Generally, when you think about dental care, you think about going to a physical dental office, a brick and mortar clinic, whether that's a private practice or a community health center. This came with a lot of barriers. There's transportation barriers, limited hours. It was inaccessible for a lot of people with disabilities. And so for a long time, there have been programs to bring dental care to people in community settings, primarily dental hygienists, sometimes expanded function dental assistants, being able to go into places like schools and nursing homes and offer preventive care. And other states have had a lot of success with adding dental therapists to that as well. So what they're able to do is provide more care in those community settings and have to refer a lot fewer patients back to the dental office. So that's been a really effective way of getting more people actually sort of the comprehensive care they need. Also, telehealth is creating a lot of new opportunities, both for supervision of dental providers, for a dentist to supervise dental assistants, dental hygienists, dental therapists who are working in community settings, as well as even doing evaluations of patients where a dental professional using telehealth, something as simple as a FaceTime call, can do a screening on a patient if they're in pain, trying to figure out what's going on. Do I need to send you to like an ER to urgently get an antibiotic right now? Can this wait until tomorrow? Like what exactly is going on? The science of dentistry is also changing. So you may have heard of there are new medicines that can actually reverse or arrest early stage cavities. All of this sort of new type of care is frequently lumped together in something called minimally invasive care. The idea being that it's less invasive. It doesn't usually involve drills or injections. As you would expect, a lot of patients are really excited about this, as those are things that a lot of people have a lot of trauma and fear around. So the idea that I might not need my tooth drilled, you might be able to do something topical. it's completely painless to me to sort of pause this cavity. Is really exciting for a lot of people, but this is still kind of like a big culture change in dentistry, and a lot of dental providers are not offering this care yet. And I would also say that, I think in all of the excitement around these new sorts of treatments, it's really important to remember that patients should be the ones making the choices about what's right for them. Sometimes a patient may say, you know what, I understand there's these newer treatments, but I would like more the tried and true one. Or, you know what, some of these ones will also mean you might have to come back more regularly. You might need to come back every 3 months as opposed to you don't have to come back for 12 months. And they say, actually, that's going to be a barrier for me. So I think it's always really important to remember that patients should be being presented with options and able to make informed choices about what's best for their own lives. As we've also talked about, there's been a big split between dentistry and medicine for a very long time, but we are starting to heal that split a little bit. And that split has been not just providers and where it's delivered, it's the insurance, it's even health records. It's the fact that most dental and medical providers can't see one another's health records, so they don't know what's going on with the full picture of a person's health. But there's a lot more push for integration. And some of that can mean having dental providers in medical settings. Like I know of dental hygienists who work in pediatricians' offices, or dental therapists who work in emergency departments. I know a dental therapist who works a couple days a week in an OBGYN office, or another one who does rounds every morning at a children's hospital in Alaska. So the idea that having these providers as part of the medical team is really exciting. And we also see some medical providers being able to actually do some oral health services. So fluoride varnish has been something that has been done in a lot of pediatricians' offices for a long time. But SDF, which is silver diamine fluoride, which is one of those medications, topical medications that used in the minimally invasive care, can also be done by medical providers. There's more oral health education being offered by medical providers as well. So there's a lot of efforts to try to figure out how can we get as much care to somebody when they're in a healthcare setting as possible, and also try to cross-train medical and dental providers. There's also generally sort of shifts in what practices look like. If you sort of imagine the traditional idea of a dental practice being sort of like a solo provider, sort of out there in their own little office, there's for decades now, there's been a lot of shift. First, it was a shift to more sort of group practices. But there's also a rise in sort of what we call dental support organizations, which is basically sort of more like chain dental clinics. You may have heard of some of the big ones are like Aspen, Heartland, Western Dental. I don't want to paint all of these different groups with a broad brush. A lot of them do have a lot of backing from Wall Street and private equity and are growing a lot. I think some of them provide some really great care, but there are also concerns and concerning stories out of a lot of places of some of these chains sort of providing poor quality care or a lot of overtreatment issues as well. So I think we need to really be making sure that that sort of the profit-driven dental industry is always protecting patient health. And I would also say generally there's momentum away in all of healthcare from what we call fee-for-service, with the idea that you do a filling and you get X number of dollars, that it's just this very sort of simple, you do X, you get Y, and more towards other payment models like a value-based care, which is a lot of people are trying to figure out what would that look like. And in dentistry, where so much is focused on sort of treating the disease, a lot of this is a shift towards keeping people healthy, which I think is a really exciting idea, but also is going to take a lot of sort of broad shifts. So now I have a discussion question for the group as well. And I'm also going to say that I know the chat has been pretty active, but I cannot present and read the chat simultaneously. So I'm going to take a minute to catch up on the chat. So we are going to go out into breakout rooms for a few minutes, and I'd love folks if you could discuss what would your ideal oral health care system look like. If you are able to sort of separate yourselves from a lot of the what does it look like right now, but what would it really look like if you felt like this was a healthcare system built around, the needs of communities or around, the folks that you work with. All right, everyone, welcome back. I hope you had a good discussion in your group. does anyone have anything that they'd like to share from their group?
I can go. So in our group, we talked about our dream world of dental oral health care systems, and we talked about wanting it to be affordable, accessible, to also have education along with your appointments to prevent future problems in your mouth. What else did we say? We also said that we would like it to be like somebody mentioned that they saw a clinic that had daycares in it, so that when people go to their appointments, they could drop off their kids there and get care and not be worried about their kids' well-being. We thought that would be a really cool thing to have at dentist appointments. Because sometimes parents don't show up to their dentist appointments because they have other responsibilities. But yeah, that's just a little bit of what we discussed. I don't know if I remember everything, but that's what I remember.
Thank you. I can't agree more with everything you said, like rebuilding a system around the patients. That sounds beautiful. Anyone else have something they want to share?
Definitely a medical dental integration, but also a better referral system between the two instead of just word of mouth saying, go see a dentist, like a better, more effective way of referring patients to go see a dentist for sure.
Absolutely. I've heard so many stories from folks being like, oh, well, they told me I needed to, follow up with a dentist or something. And I was like, oh, do you have any idea who? And they're like, oh, you can just Google, or particularly if you're on Medicaid, oh, there's just a list. But then you start calling down the list, and most of the places aren't taking new patients or any of this. So yeah, if there could actually be an integrated system where you could get, where your provider would know who to send you to and help you get that appointment. Anyone else have something they'd like to share? No? All right. So just a couple more slides to kind of wrap all of this up. So, as we have sort of talked about as a constant theme through this sometimes downer of a presentation, oral health equity is a major issue in the United States, really globally, but we're only talking about the US here. Specifically, people of color and low-income communities are far less likely to get dental care. And due to the history of structural racism in this country, those are not unrelated groups. There is a reason that communities of color are overrepresented in low-income communities. So we know that they're less likely to get dental care. They are more likely to have dental disease, and they are more likely to suffer the effects of untreated dental disease. And so this is really for a privilege for a lot of people to not know that this is an issue. And I should say, when I first started working on oral health years ago, I realized it wasn't something, I was like straight out of college and I wanted a public policy job, and I thought, okay, I guess I can do that. But I didn't really have what I felt like was a connection to the issue. And I'd gone to the dentist as a kid, and I thought everyone went to the dentist. I started learning about this work, but I also started having conversations with other people in my life. And my mom, who grew up in poverty after her father died, in a big family in rural Midwest, was like, oh yeah, I didn't see a dentist until I was 18. I was like, I'm sorry, what? And she was like, yeah, she was on, public insurance. And she's like, yeah, we just didn't have dental care. And you start hearing these stories all over, and you realize that this is actually a constant theme through so many people's lives, and hearing stories about people putting off dental care because they can't afford it, and the impacts of that on their lives. So this is just such a constant story, and it's a story all across the country, and it's a story in urban areas and in rural areas. But it's one that I really hope we don't have to keep telling, and something that we can really make a change about. So if I had to also sum up what is, in my view, at least sort of the major failings of our oral healthcare system, is that, our oral health care system sort of works as it's intended in a lot of ways, because it was built for privately insured patients with disposable income, without disabilities, in middle to high income, like urban and suburban areas with good transportation and flexible jobs. And if all of those things describe you, you maybe don't have you've probably maybe not had a lot of experience accessing, having challenges. But if you do not meet all of those definitions, and the more of them you do not meet, the more compounding barriers people are likely to have to accessing oral health care. We know that dental professions are not representative of the broader profession, and a lot of patients have experienced discrimination and trauma when interacting with the dental care system. And as we've talked about, we know that BIPOC communities, low-income communities, people with disabilities, seniors, folks in rural communities, they're all much less likely to be getting dental care and more likely to be experiencing dental disease. So just a quote from a listening session that we did last year. The community member said, people who are not poor don't understand that when your priority every day is putting food on the table and finding a place to live, other issues that are not pressing you at the moment sometimes get pushed to the back burner. And so, like, if I had to leave you with a single message, it would be that communities care about oral health. I've heard again and again in listening sessions and in getting to talk with people all across the country that people care about their oral health, but for a lot of people, they feel like the oral health care system doesn't care about them. And something I've heard in dental spaces frequently is that the idea that fixing our oral health care crisis in this country is going to come down to teaching patients to make better choices, whether those are better choices about sugar or about toothbrushing, or better choices about how people spend their money so that they can afford dental care. And while obviously diet and oral hygiene are important, I don't mean to suggest they're not. I think it's really important that people understand that this is very often less a case that certain people make better choices and more that some people have better choices available to them. And that it is impossible to solve structural and systemic issues at an individual level. We know that the causes of dental disease are complex and that we can't talk about them without considering the social determinants of health. And we look at all of these things, access to healthy food and clean fluoridated water, at racism, discrimination, violence, and trauma, at language and literacy, at housing, transportation, and geography, at education, job opportunities, and income. All of these things are impacting people's ability to get oral health care, which means that we need to think about them in the policy solutions we are trying to implement, and also realize that sometimes to solve an oral health care crisis, we need to look at policies that are not just about oral health. People's lives do not exist in a vacuum, and that's why our solutions shouldn't exist in one either. So I want to thank everybody for letting me come and talk to you today.